Imagine your own immune system just mistakenly deciding that your most intimate anatomy is a threat.
Yeah, it's a pretty terrifying concept.
Right, like actively fusing the skin together and turning everyday friction into absolute agony. We aren't talking about, a cosmetic annoyance or just a temporary rash here.
No, not at all.
We're stepping into the diagnostic landscape of a chronic inflammatory disorder that,
Yeah.
well, it fundamentally alters the mechanics of the human body.
It really does. It changes everything.
So today, for you listening, we're pulling from a big stack of medical guidelines, NHS materials, and recent clinical studies. And the mission for this deep dive is to answer a crucial, often unspoken question.
Does lichen sclerosus, or LS, affect sexual intercourse?
Exactly.
Yeah.
And if it completely dismantles a person's intimate life, how do they actually go about rebuilding it? Okay, let's unpack this.
Well, to tackle the mechanics of how this impacts intimacy, we first have to isolate what LS is actively doing to the tissue itself.
Right, because it's not an infection, is it?
No, it's an autoimmune-mediated condition. So the body is driving this relentless inflammatory response, mostly targeting the genital and perianal areas.
And visually, what does that actually look like?
Visually, it creates these distinct white, thinned out, or sometimes thickened patches of skin. In female patients, you'll frequently see this classic figure-of-8 pattern that encompasses the vulva and the anus.
Wow. Right.
But we need to immediately address a massive shadow that hangs over this diagnosis. Because it presents on the genitals, the immediate assumption is often that it's a sexually transmitted infection.
Which obviously brings a massive amount of stigma and, frankly, panic into a relationship right off the bat.
It really does, yeah. And it's a completely unfounded fear. Lichen sclerosus is absolutely not an infection.
So you can't pass it on.
Impossible. It is impossible to transmit to a partner during sexual intercourse. You cannot catch it from someone else. It's an internal systemic error, not an external pathogen.
That distinction is vital. I mean, it completely changes the conversation a patient has with their partner. But even without the fear of transmission, the literal physical reality of LS is just staggering.
It is.
If we want to understand the impact on sex, we have to look at the structural changes happening to the anatomy, right?
Yeah, the structural degradation is really where the barrier to intercourse begins. In the female anatomy, this localized inflammation fundamentally degrades the collagen and elastin networks within the skin.
So it loses its stretch.
Exactly. The tissue loses its integrity and becomes extraordinarily fragile. We're talking about skin that can fissure or split from the ambient friction of simply walking around or, wearing denim.
So if the ambient friction of just existing is causing micro tears, introducing the targeted friction of sexual intercourse is going to be excruciating.
Absolutely excruciating.
It sounds like trying to stretch a piece of dry, delicate tissue paper. The slightest tension, and the structure just fails.
That's a very accurate way to picture it, yeah. And the mechanical failure goes beyond just the tearing. If that inflammatory cascade isn't therapeutically suppressed, the anatomy undergoes radical architectural shifts.
Architectural shifts, like what?
Well, the chronic inflammation triggers fibrosis, which is scarring. So the labia minora, the inner lips, can actually atrophy and fuse to the labia majora.
Oh, wow.
And the vaginal opening itself can suffer from introital stenosis.
Which means the entrance is actually shrinking and narrowing.
Yes. As the elastin is destroyed and replaced by rigid scar tissue, the vaginal opening loses its capacity to distend. It just becomes a fixed and flexible ring.
That sounds incredibly painful.
It is, and perhaps the most psychologically distressing architectural change involves the clitoral hood. This fold of skin can scar over and fuse completely, literally burying the clitoris beneath a wall of fibrous tissue.
Wait, I have to ask a clarifying question about that because reading that in the clinical materials was frankly terrifying. If the clitoral hood fuses completely, does that mean the anatomy is actually gone or damaged underneath?
What's fascinating here is that the underlying architecture remains completely viable. The clitoral complex, including the glands, is actually untouched by the disease process itself.
Wait, really? It's still fine.
It is. The autoimmune attack is targeting the epidermal layers covering it. The organ is perfectly intact, it's simply trapped.
That is a massive paradigm shift for a patient's body image. I mean, it's the difference between grieving an amputation and dealing with a locked door. The function is still there.
Exactly. It provides a profound sense of hope when initiating treatment. And, while the clinical literature heavily features the female experience, The data clearly shows this condition aggressively alters male anatomy as well.
Right, I wanted to touch on that.
Yeah, though it's remarkably rare in men who were circumcised in infancy in uncircumcised men, LS aggressively targets the foreskin and the glands.
I was reading about phimosis in the sources.
Mhm.
How does LS drive that specific complication in men?
Well, the inflammatory scarring causes the foreskin to lose its elasticity, so it becomes thick and rigid. When an erection occurs, the penile tissue engorges and requires that skin to stretch and retract.
But the scar tissue won't let it.
Right. The fibrotic foreskin acts like a tourniquet. It just cannot yield. This creates a painful wasting effect around the shaft, and the fragile skin on the glands will often split and bleed under the tension of intercourse.
I miss.
In extreme cases, the scarring can even creep into the urethra, restricting urinary flow.
So the physical barriers are immense for both men and women. You have structural shrinking, tearing tissue, and literal anatomical fusing.
Very much so.
But treating this purely as a physical, mechanical failure seems incomplete to me. When a human being experiences that level of pain during something that is supposed to be intimate, well, the nervous system doesn't just isolate the pain to the pelvis, does it?
No, not at all.
It has to trigger a massive neurological domino effect.
It creates a feedback loop that completely hijacks the body's sexual response cycle. You really cannot divorce the biomechanics of sex from the neurology of arousal.
So what happens in the brain?
When a patient with uncontrolled LS is approached for intimacy, their sympathetic nervous system doesn't register an opportunity for pleasure. It registers a threat. The brain anticipates the agonizing tearing of tissue and triggers a full defense cascade.
Which means anxiety spikes, and anxiety is essentially the ultimate chemical roadblock for arousal.
Precisely. The physiological requirements for comfortable intercourse, vasocongestion, tissue expansion, natural lubrication, they are biologically impossible when the body is flooded with cortisol and adrenaline.
The body just says no.
Right. The nervous system is prioritizing survival over reproduction, and this threat response generalizes very quickly. The sources document patients who begin withdrawing from all forms of physical affection.
Like completely.
Yeah, they won't hold hands, they won't cuddle, or even accept a hug.
Because they're terrified that any physical touch is just a ramp up to intercourse. They shut down the entire tactile connection to protect themselves from the eventual pain.
Exactly.
But how does that affect their underlying desire? Does the sex drive just evaporate entirely?
Well, to understand that, we have to pull apart the mechanics of human desire. The literature differentiates between spontaneous desire, which are those unprompted internal cravings for intimacy, and responsive desire.
No, we use responsive desire.
Responsive desire relies on external stimuli. The arousal builds as a reaction to pleasurable touch, a relaxed environment, and emotional connection.
Oh, here's where it gets really interesting. If a person relies primarily on responsive desire, an LS has rewired their nervous system to interpret touch as a threat.
The responsive desire circuit is completely severed. The touch isn't generating pleasure anymore, it's generating dread. Therefore, the desire just never manifests.
And there's a secondary, completely involuntary physical reaction that happens alongside this psychological dread, isn't there? The sources highlight this intense muscular reaction in the pelvis.
Ah, yes. The pelvic floor defense mechanism. The pelvic floor is a complex network of muscles supporting the pelvic organs and surrounding the lower third of the vagina.
Right.
Even if a patient consciously wants to be intimate, that deep-seated neurological anticipation of pain causes those muscles to contract violently and involuntarily.
It's basically the body throwing up a shield.
Exactly.
But the tragic irony here is that by clamping down to prevent the trauma, those muscles shrink the vaginal canal and make it entirely rigid. The defense mechanism guarantees that any attempt at penetration will cause the exact micro-tears the body is trying to avoid.
It is the ultimate vicious cycle. The physical fragility causes pain, the pain causes neurological dread, the dread causes a muscular spasm, and the spasm amplifies the physical tearing.
Wow. We've mapped out a pretty bleak trap here. I mean, the anatomy is compromised and the nervous system is in full revolt.
It sounds hopeless, but it isn't.
Right, because the overwhelming consensus of the medical guidelines we're reviewing is that patients do not have to live in this trap. So how do we disrupt this cycle? Let's talk about reclaiming the mechanics.
The absolute first step is halting the autoimmune attack. You have to put out the fire before you can rebuild the house.
Makes sense.
The gold standard across the medical guidelines is the application of ultra-potent topical corticosteroids, specifically clobetasol propionate.
Now, I want to push back on that for a second because Anyone who's used over-the-counter hydrocortisone knows the cardinal rule. Long-term steroid use thins the skin.
Right, that's what we're all taught.
So why on earth are we applying ultra-potent steroids to tissue that is already tearing like wet tissue paper?
It seems entirely counterintuitive, I agree, but the histology of the genital mucosa is unique. These specific tissues are remarkably resistant to steroid-induced atrophy.
Really? They don't thin out.
Very rarely. The far greater threat is the disease itself. Uncontrolled lichen sclerosus destroys the dermal architecture far more aggressively than the treatment ever could.
Okay, that makes sense.
The clobetasol suppresses the inflammatory cytokines, which allows the skin to actually heal and regain its elasticity. And most importantly, it completely halts the progression of fibrosis and fusing.
And for anyone wondering about their partner, the guidelines are clear that this doesn't spell the end of spontaneous intimacy.
No, not at all.
You don't have to worry about transferring a massive dose of steroids to your partner. You simply wipe away any residual ointment before intercourse, or structure your routine to apply the medication afterward.
Exactly. Once the inflammation is suppressed, you have to manage the friction. Lubrication is paramount. But the interactions between these medical treatments and barrier contraceptives create a highly volatile situation.
Right. There's a massive flashing warning in the NHS materials regarding lubricants. Why are the sources so adamant about avoiding oil-based products during sex?
It all comes down to the chemical degradation of latex. Many patients use plain petrolatum, like Vaseline, as a daily barrier cream to protect the fragile skin from urine.
Yeah.
Or their prescribed steroid is suspended in a heavy ointment base. Well, if those oil-based hydrocarbons come into contact with a latex condom, they dissolve the integrity of the latex almost instantaneously.
It.
Basically, yes, the condom will fail. Therefore, if a patient is utilizing condoms for contraception or STI management, they must ensure the area is entirely clear of ointments and rely exclusively on high-quality water-based lubricants.
Good to know. So we have the steroids handling the inflammation and the water-based lube eliminating the friction. But what about the pelvic floor spasm? What if the brain is still anticipating pain and locking the muscles down?
The guidelines offer a two-pronged approach for the lingering pain and muscle tension. Neurologically, physicians will often prescribe a 5% lidocaine ointment.
So a numbing cream.
Exactly. The patient applies this local anesthetic to the vulva and the entrance of the vagina about 15 minutes prior to intimacy.
Which temporarily severs that pain signal to the brain.
It blocks the voltage-gated sodium channels in the nerves, halting the transmission of the pain impulse entirely. This allows the patient to experience touch without the immediate threat response.
That's brilliant.
But critically, it must be thoroughly removed before penetration. Otherwise, the partner will absorb the anesthetic and lose all sensation as well.
Well, that would certainly defeat the purpose of the exercise.
It definitely would.
And for the physical tightness, like the introital stenosis you mentioned.
Patients utilize graduated vaginal dilators. By combining these smooth cylinders with targeted physical therapy, they can gently stretch the fibrotic tissue over time.
And that helps the muscles too.
Crucially, yes, it retrains the pelvic floor muscles to accept penetration without triggering that involuntary spasm.
Got it. Now, beyond the ointments and dilators, I noticed the clinical studies section delving into some fairly advanced interventions. What is the mechanism behind using fractional CO2 and erbium lasers for LS?
These lasers are becoming a highly compelling secondary option. They aren't continuous beam lasers used for cutting tissue like you might picture.
Okay.
They emit. If we connect this to the bigger picture, treating a menopausal patient with LS requires a dual therapy approach because the symptoms actually compound one another.
How so?
As systemic estrogen drops during menopause, the vaginal mucosa naturally becomes thinner, less elastic, and highly prone to microtears anyway.
So a patient could be perfectly compliant with their ultra-potent steroids, effectively suppressing the autoimmune attack, but still experience agonizing pain because they are fundamentally estrogen deficient.
Precisely. The steroid cannot replace a missing hormone. It only treats the surface inflammation. This is why specialists routinely prescribe localized intravaginal estrogen therapy alongside the clobetasol.
To tackle both issues at once.
Right. The estrogen binds to the receptors in the mucosa, restoring blood flow and hydrating the tissue internally, while the steroid holds the autoimmune disease at bay externally.
It's a beautifully logical combination.
Yep.
But let's step away from the purely biological interventions for a second. You can remodel the collagen, suppress the cytokines, and hydrate the tissue all you want. But healing the microscopic architecture of the skin doesn't automatically heal the intimacy of a relationship, does it?
No, it doesn't. The isolation this disease imposes on a partnership is immense.
Yeah, I can imagine.
Because the symptoms are often invisible to a partner during day-to-day life, and because the patient's neurological dread causes them to withdraw from all physical affection, the partner frequently misinterprets the distance.
They perceive it as a loss of attraction.
Or a personal rejection, yeah.
And then the resentment builds because the communication is broken down. The literature emphasizes that the patient has to demystify the condition for their partner, but crucially, not in the bedroom.
Definitely not.
You don't try to explain autoimmune fibrosis while someone is attempting to initiate intimacy. You sit down in a neutral environment and explain the mechanical reality. My immune system is tearing my skin, my nervous system is panicking. It isn't a lack of desire for you.
Taking the emotional rejection out of the equation is just mandatory for rebuilding trust. And the sources also acknowledge how paralyzing this disclosure can be for single individuals attempting to date.
Right. The Oxford University Hospital's leaflet actually offers a brilliant tool for this, the single life script.
I love this tool.
Instead of fumbling through a complex medical explanation in the heat of the moment, you just have a rehearsed boundary ready to go. You say, I have a skin condition called LS. Please can we take sexual touch slowly and see how it feels? I will let you know what works for me.
It's so empowering.
It really is.
Yeah.
It establishes authority over your own body and removes the anxiety of the unknown for both people.
It's a highly effective way to navigate new intimacy, but the most profound conceptual shift recommended in the Oxford materials fundamentally challenges our cultural definition of sex itself. They introduce the concept that sex is a menu.
So what does this all mean? I think this is the most liberating concept in the entire stack of research we looked at today.
It really reframes everything.
Culturally, we operate on this rigid hierarchy of intimacy. Penetration is viewed as the main course, and everything else, massage, external stimulation, mutual touch, is relegated to just foreplay.
Right, something you just get through.
It's just the appetizer you rush through to get to the real event.
But the menu analogy dismantles that hierarchy entirely. It suggests that if your anatomy is currently compromised or your pelvic floor is in spasm, you simply take penetration off the menu.
And taking one item off the menu doesn't mean the restaurant is closed.
Exactly.
There is a vast array of intimate, deeply pleasurable acts that do not require stretching fibrotic tissue or challenging a spasming pelvic floor. Foreplay doesn't have to be the appetizer. It can be the entire meal.
This raises an important question, however, about the psychological flexibility required to accept that.
Yeah, that's true.
Grieving the loss of spontaneous penetrative intercourse and rewiring the brain to focus on alternative pleasures is incredibly difficult. This is where psychosexual therapy becomes a vital component of the treatment protocol.
So how does a psychosexual therapist actually help a couple rewire that neurological dread we talked about earlier?
They utilize structured behavioral interventions, most notably a practice called sensate focus. The goal is to completely dismantle the performance pressure and the anticipation of pain.
How do they do that?
A therapist will instruct the couple to engage in physical touch with strict boundaries, perhaps starting with clothes on and an absolute ban on any genital contact or goal-oriented sexual activity.
So they're essentially tricking the nervous system.
Yeah.
By taking sex entirely off the table, the brain realizes it doesn't need to trigger this sympathetic threat response.
Yes, they are slowly mapping safe touch. As the nervous system realizes the touch will not lead to trauma, the anxiety dissipates.
That makes total sense.
Over weeks or months, the boundaries are slowly expanded. It bridges the gap between the medical treatments healing the skin and the emotional interventions healing the relationship.
So for everyone listening, to pull all of these threads together, Lichen sclerosus is a systemic, architectural, and neurological disruptor. It aggressively alters the integrity of the genitals and creates a complex feedback loop of pain and anxiety.
It's a heavy burden.
But the data is definitive. It does not dictate the end of a fulfilling, intimate life. By fiercely advocating for the right combination of ultra-potent steroids, localized estrogen, and physical therapy, the mechanical barriers can be managed. And when paired with radical communication and a willingness to redefine intimacy, a sex life can absolutely be rebuilt.
The clinical pathways are clear, but the journey requires immense patience and psychological adaptation. And, this leads to a vital perspective to consider moving forward.
What's that?
We instinctively view chronic conditions like lichen sclerosus as profound losses, thieves that strip away our physical spontaneity and our definition of normalcy. But look at the toolkit required to reclaim intimacy here.
It's pretty extensive.
If a condition forces you to communicate with your partner with absolute unguarded honesty, if it demands that you slow down, dismantle the cultural hierarchy of sex, and practice deep mindful presence with your body, could this diagnosis paradoxically become the catalyst for a more creative, resilient, and profoundly connected intimate life than you ever thought possible?
That is such a powerful thought to leave on. Thank you to our listeners for joining us on this deep dive. Keep asking questions, keep advocating for your health, and we'll see you next time.